Hello, I am Dr. Richa and in this video we will discuss about Alzheimer disease. Alzheimer disease is the most common cause of dementia in older adults. Basically, there is memory loss. So as the population ages, we see more and more new cases in that population. So what happens in Alzheimer's disease? Alzheimer's disease is a disease of neurodegeneration. That means there is slow loss of neurons progressively. And this happens sequentially in different regions of the cortex. So first affected is the medial temporal region, where basically the hippocampus is located, and hippocampus is a region which is having the function of consolidation of memory. So that means new events are converted to long-term memory by this region of the brain, that is hippocampus. So when there is loss of neurons in this region, there is no memory of recent events. Yes, why recent events and not long-term memory? See, once any new events occur, we experience any new event, then the information is passed to the hippocampus, and then by consolidation of the memory, it is converted to long-term memory, and long-term memory is stored in various regions of the neocortex. So first thing which happens is loss of recent event memory, and later on, with involvement of more and more cortical regions, there is loss of long-term memories as well. So there is a sequence of neurodegeneration I was talking. Initially, there is the temporal lobe. In fact, the medial region of the temporal lobe is affected. Then there is lateral temporal regions which is affected. Then lateral parietal regions affected, and then frontal regions affected. So because the degeneration is happening in a particular sequence, that means the clinical features also which are going to happen, they are going to form a characteristic pattern. So first is basically loss of memory of recent events. Then with the involvement of the lateral temporal region, there will be language difficulty. Language difficulty because the Wernicke's area may be involved. And first what we see is word finding difficulty. The person doesn't know what is the word for a particular thing. And that is generally not taken seriously. Okay. But the person himself may be aware of that. Okay. So there is self-awareness of that yes, some problem is happening, my memory is not working fine, but the other people will not realize. And only later, with the problem in the memory and word finding difficulty, there is comprehension problem also arising, then only people may realize that yes, some problem is occurring. Then with the involvement of the lateral parietal region, parietal cortex is the region of somatosensory cortex. Okay, there the sensory information is reaching. So there is visuospatial disorientation. The person forgets that where he is going, he doesn't understand where he is. Okay. Then with involvement of the frontal cortex, there is problems in the personality and judgment. The person is not able to decide anything. So how this neurodegeneration happens? That happens, the key event being the accumulation of plaques and tangles. Accumulation of plaques and tangles. Actually, this accumulation of the plaques is the main inciting factor for the disease. And this accumulation of plaques and tangles, in fact, is the hallmark of Alzheimer disease. Hallmark of Alzheimer disease. But remember, these tangles can be seen in other diseases as well. In fact, this plaques is the pathognomonic feature of Alzheimer disease. Okay, so main pathophysiology is accumulation of plaques, which ultimately leads to formation of the tangles. And what are these plaques and tangles? Plaques is the accumulation of A beta protein, that is amyloid protein, and tangles is the accumulation of hyperphosphorylated tau protein. So what are these? Plaque is basically, I told you, it is accumulation of A beta protein. Now, if you see this diagram, here this is the membrane of the neuron, and here this protein is present, that is amyloid precursor protein. This protein has an extracellular domain. So this part is extracellular domain that is present outside the cell. This part is the intracellular domain, that is the cytoplasmic domain, and this is the transmembrane domain. So this is a single transmembrane domain. Now, this protein is required for many functions in the nervous system. But like any other protein, it undergoes a turnover. So, there is cleavage of these proteins. Plaques are generated by abnormal cleavage of amyloid precursor protein. So, what happens? Actually, there are different types of proteinases. These are known as secretases. There is alpha secretase, there is beta secretase, and there is gamma secretase. Alpha secretase breaks down this part of the protein, and gamma secretase cuts somewhere here. Okay, actually this yellow and red line should be little bit above. So we get these fragments and we get this particular central fragment, and this fragment is soluble. So by the action of alpha secretase and gamma secretase, we get a amyloid protein segment which is soluble and does not precipitate. However, if certain risk factors are present like increasing age, then this beta secretase activity increases, and this leads to production of insoluble protein, because this beta secretase acts here. Okay, so it removes this part of the extracellular domain, and this full amyloid protein is generated which is insoluble. So this is the A beta component which is insoluble, and it is produced with the action of beta secretase and gamma secretase. So once this A beta component is produced which is insoluble, it has a tendency to form oligomers. That means all these A beta proteins will form some aggregate, and finally it will form a bigger aggregate. So these are known as A beta aggregates and fibrils. Okay. By the way, the breaking down of this APP protein by alpha secretase and gamma secretase, that is known as the non-amyloidogenic pathway. Non-amyloidogenic pathway. While when beta secretase and gamma secretase are involved, that is known as the amyloidogenic pathway. Amyloid protein is being produced, that is the A beta component. So that is why it is known as amyloidogenic pathway. Okay. Now, I told you that this accumulation of A beta aggregates and fibrils is the critical initiating event. And when this happens, now the various problems start, and one of this is interference with the signaling. So this A beta aggregates deposit somewhere here. So there is interference with the synaptic transmission from one neuron to the other. Then it also initiates inflammation. So there is response of the astrocytes and microglia. In the central nervous system, astrocytes and microglia are responsible for inflammation. And these bring about other changes which ultimately lead to neuron death. Okay. So we see that deposition of these A beta aggregates extracellularly, outside the neuron these are getting deposited, extracellularly leads ultimately to the neuron death. Then these plaques also get deposited in the blood vessel walls, and this is known as amyloid angiopathy. Though it is not characteristic only of Alzheimer's disease, but it is also seen in Alzheimer's disease. So this is another pathological feature of Alzheimer's disease. Now, how these amyloid plaques appear? So here is a histological slide showing amyloid plaques. There is central amyloid core surrounded by spherical dilated neuritic plaques. Okay, what is neuritic plaques? Neurites refer to the extension, the projections from the cell body of the neuron. Okay, so if this is the cell body of the neuron, whatever projections come out of the cell body of the neuron, whether it is dendrites or they are going to form the axon, that are known as neurites. So neurites are the preliminary extensions, we can say, which occur from the neuron. So there is accumulation of this dilated tortuous neuritic plaques surrounding this amyloid core. And this amyloid core can be better stained with a stain that is Congo red. Congo red. Okay. And where is this deposition? This is extracellular deposition. Now moving on to the next pathological feature, that is accumulation of hyperphosphorylated tau. Tau is a protein which is associated with the microtubules. Okay. Microtubules is basically cytoskeletal network. Okay. Now this cytoskeletal network of microtubules extends from the cell body to the axon like this. It is like tracks, and it is basically for the transfer of substances from one end of the axon to the other, to and fro. Okay. For example, there can be transport of neurotransmitters from the cell body to the axon. That happens on these tracks. Now, this tau protein, which is associated with this microtubules, is important for its stabilization. It keeps it as such. When this tau protein becomes hyperphosphorylated, it detaches from these microtubules and starts getting accumulated in the cell body. It gets removed from here. It gets accumulated in the cell body and the dendrites. Okay, so then it forms somatic dendritic distribution. Before it is present in axons associated with the microtubules. Now it has moved away from the microtubules into the soma, that is the cell body of the neuron, and into the dendrite. So that is known as somatic dendritic distribution of tau. And when this gets removed, there is destabilization of this microtubules. So they break down. And now the transport of the substances from one end of the neuron to the other end of the neuron doesn't become possible. Ultimately, it leads to cell death. Okay. So there is accumulation of these hyperphosphorylated tau in the soma and the dendrites, that is known as tangles, and microtubules destabilize, ultimately leading to the neuron death. So here in this histological slide, we see accumulation of neurofibrillary tangles, and there is deposition of these tangles within the cytoplasm of neurons. So we saw that amyloid plaques deposit extracellularly. Neurofibrillary tangles deposit intracellularly within the cytoplasm. The stain for amyloid plaque, I told you, is Congo red. These neurofibrillary tangles can be stained better with a silver stain known as Belshowski stain. Belshowski stain. Okay. So what are the pathological features we saw? We saw the accumulation of the amyloid plaques, accumulation of these tangles, accumulation of amyloid in the blood vessel walls, that is known as amyloid angiopathy. So how this accumulation ultimately leads to neuron death, we have already discussed. Let us summarize a little bit. If there is presence of risk factor for A beta amyloid production, this leads to accumulation of A beta plaques, which is the critical event. These interfere with neuron signaling, ultimately leading to inflammatory response from microglia and astrocytes, leading to neuron death. Then it also leads to activation of the kinase. Kinase always causes phosphorylation. So this leads to hyperphosphorylation of tau protein, which gets separated from the microtubules, forming tangle aggregates. Then this leads to destabilization of microtubules, ultimately interfering with neuron signaling and causing cell death. Tangle aggregates within the soma and the dendrites also lead to initiation of the inflammation, which also lead to cell death. Okay. Now, what are the gross features which are seen? And these are seen at autopsy, or these days it can also be seen in PET scan. So what are these? See, this side it is showing normal cerebral cortex and the other side is showing Alzheimer's disease. So in normal cerebral cortex, we see thick cortex, narrow sulci. Sulci are these grooves between the gyri, okay? And normal sized ventricle is there. But in Alzheimer disease, due to cortical atrophy, due to the loss of the neurons, we see that this portion has thinned out and there is widening of these grooves because of the thinning out of gyri. There is widening of these sulci, and there is also enlargement of the ventricles, compensatory enlargement, because the area is available. So there is compensatory enlargement of the ventricles, and this is known as hydrocephalus ex vacuo. Okay, and this atrophy is seen again where the disease is affecting the cortex. So first it will be seen in the temporal cortex, and then we will see it in different areas, that is temporal, parietal and frontal cortex. Now, what are the risk factors or what are the causes for this Alzheimer disease? This Alzheimer disease can be sporadic or familial. Sporadic means that with increasing age, we see increasing the incidence of Alzheimer disease. And second is that if there is presence of this epsilon 4 allele of ApoE gene, okay, this ApoE gene is present on chromosome 19, and the protein, the ApoE protein which is produced, has a role in clearance of amyloid precursor protein. Now there are three different alleles of this ApoE protein. The more presence of this epsilon 4 leads to more production of amyloid beta. component of the clearing protein. Okay, so when more amyloid beta is produced, that means there will be more accumulation. Yeah, body tries to remove it, but more production, the body is overwhelmed and there will be accumulation of this A beta protein. Then familial is, that means we see early onset Alzheimer disease. That means if there is presence of certain risk factors which lead to more production of this A beta protein, then we will see Alzheimer disease in early onset. Normally, we see the features of Alzheimer disease starting after 70 years of age. Yes, some pathological features may be present, but the clinical features start after 70 years of age. But when we see this familial Alzheimer disease, then even at the age of 50 years, the clinical features may start. And this is seen in Down syndrome. Down syndrome is trisomy of chromosome 21. And in fact, the gene for this amyloid precursor protein is also present on chromosome 21. So because maybe that this is trisomy, that means 321 chromosomes are present, then maybe there is increased production of this APP protein and hence there is increased production of A beta protein. We are not aware that what is the exact pathophysiology. Then we have presenilin 1 and 2 mutation. Again, these mutations lead to increased production of A beta protein, okay, and hence increases the risk of early onset Alzheimer disease. Now, we will see clinical features once again little bit organized manner. So, we see insidious impairment of higher cognitive function. Insidious means slow impairment we see of higher cognitive function. So, first affected is medial temporal lobe, initial memory loss, that is the recent events, and there is disorientation as well. Then there is lateral temporal lobe problems, language difficulties and comprehension issues. Then parietal lobe is affected, so spatial awareness is lost and sensory processing decline is there. And frontal lobe is affected, leading to executive function and personality changes disorders. Now, if we summarize this, we can say that there are 4 A's in the clinical features of Alzheimer disease, that is amnesia. Amnesia is memory loss. Then we have aphasia, that is language problem. Then we have apraxia. Apraxia is when the person has trouble performing sequential motor tasks which the person has already learned. For example, washing utensils. The person will not be able to perform the task. But there is no problem in the motor system. Everything is intact. Still, there is trouble performing the sequential motor task. And then there is anosognosia. That means the person is not aware of his problem. Okay. So initially the disease starts basically with the memory loss of recent events. Slowly it progresses to long-term memory loss. The patient forgets almost everything, whatever he has learned in life. And in the later stages of the disease, in the end stage disease, the patient becomes almost mute, incontinent and bedridden. And the person will die of diseases because of being bedridden, mainly pneumonia. Now moving on to the last part, that is how to do the diagnosis and what is the treatment aspect. Diagnosis, the definitive diagnosis is only made by pathological examination of the brain tissue. But these days, with the advent of modern radiological methods and with the use of certain biomarkers, in 80 to 90% of the cases, correct diagnosis is made, which is finally confirmed by autopsy at death. So, first we have to exclude other causes of dementia, that is by clinical features, by doing radiological assessment, that is CT and MRI. And we can also look for the biomarkers in CSF. In CSF, decrease in A beta protein and increase in the levels of hyperphosphorylated tau. That is a sign of Alzheimer disease. And PET scan using radio tracers, which are basically bound with amyloid binding compounds. Okay. So these are used, injected before the PET scan. These go and bind with the A beta protein. And if there is presence of this A beta protein, then we can think of Alzheimer disease. However, remember, we have also seen that this A beta protein is present within the vessels as well. And I told you that amyloid angiopathy is not the hallmark of Alzheimer disease. It can be seen in other diseases as well. So, we have to correlate with the clinical features, how it is happening, with the other features seen in CT, MRI, and the CSF features to make the clinical judgment. On the other hand, if we don't see any A beta protein in the PET scan, that means in that case Alzheimer disease is unlikely, isn't it? So that is the diagnosis. In MRI, if it shows temporal cortex atrophy, then also it is suggestive of Alzheimer disease. Temporal cortex atrophy. Okay. So basically it is a disease of exclusion. We have to exclude other diseases, and nowadays with PET scan we can see amyloid deposits in the brain. Okay. Now what is the physiological basis of treatment? Till date there is no cure for the disease. Main target of the therapy is counseling of the patient, family members, caregivers, because the patient needs extreme care as the disease progresses over time. Nowadays, certain drugs have been approved to slow down the disease progression. One of this is cholinesterase inhibitors, which is given to mild to severe Alzheimer disease patients. Examples being donepezil, rivastigmine, galantamine. So they prevent the disintegration of acetylcholine and increase the acetylcholine levels in the brain. And they have been shown to improve memory and attention. NMDA antagonist, it is approved for moderate to severe Alzheimer disease, not for mild Alzheimer disease, moderate to severe Alzheimer disease. And this decreases the glutamate toxicity. If there is excessive glutamate release in the cortex, it acts on NMDA receptors, which are glutamate receptors, and that also damages the neurons, that is neurotoxicity. So this NMDA antagonist prevents this neurotoxicity. Now, recently there has been search for drugs that target clearance of this A beta protein, and one of that is aducanumab. Okay, this is a monoclonal antibody which targets the clearance of this amyloid beta protein, and this has been approved in some countries for the treatment in mild cognitive impairment in Alzheimer disease, but it should be diagnosed Alzheimer disease. Okay, if PET scan actually showed the presence of A beta amyloid in characteristic areas like in hippocampus, and there is a presence of CSF biomarkers, then in mild cognitive impairment, this aducanumab can be given for clearing the A beta deposits. So that was about Alzheimer disease. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.